Good morning, everyone. Here, I'm going to set up this camera here also. Hopefully we're getting a good connection. Good morning, everyone. Welcome to PT on Ice Weekly Show. My name is Jessica Davis. I am part of the Institute of Clinical Excellence faculty. I'm the lead faculty for the Performing Arts Division. And today I wanted to talk about, so my inspiration today for my topic is my father. And with Father's Day this past Sunday, it inspired me to talk about this. So we as a family have been going through a little bit of a difficult time. And normally I wouldn't share that information, but my father specifically asked me when he was going through this to share this as an educational thing. So I am going to talk about this because I feel it's important to share. So bear with me. Okay, so what I'm going to talk about today is the diabetic foot and what we as clinicians need to do to address this and how we can have a huge impact on our patients. We learn about it in school, and I remember learning about it and thinking, okay, well, if I have a patient who has diabetes, I'm aware of what to look for. But I had no idea how incredibly rapid the progression of a diabetic foot ulcer can be and how debilitating. So let me tell you a little bit about my father. This is with his permission, of course. So, and it's interesting how he is, he leaned over to me and he said, share this and teach this. So this is in honor of him. So my father woke up one morning a few weeks ago with severe foot pain and relatively no trauma, nothing that would be in the history that would indicate anything was wrong. So if you look at differential diagnosis, one of the things that a diabetic patient, and mind you, my father's type 1 diabetic juvenile onset. However, this can occur for both type 1 and type 2 diabetics. So it's important to be aware of this. So acute onset of a swollen foot with relatively no trauma, on your differential diagnosis list, it's imperative that you consider Charcot Foot. So Charcot Foot is the loss, a rapid loss of the midfoot. So it's imperative that this gets treated early. Why? Because if it's treated early, it can be casted appropriately and it can minimize the development of the relatively flat foot and rigid foot that can result. Once it does become rigid, the issue is that it can make the patient very highly susceptible to developing a diabetic foot ulcer and unfortunately the risk for amputation. So my father presented with this, and so they addressed it appropriately. They did imaging, they confirmed it was the Charcot foot. However, when he was in the hospital, on his opposite foot, they detected a very small ulcer or wound. And this is why I want to talk about this, because my father has been very well educated and empowered as a patient. And so he's worked with wonderful clinicians who have taught him how to manage his foot and how to prevent this. So this was something that had developed very quickly. And they did a culture of this wound. Excuse me, sorry, this is my cat who's jumping on no, get off. Sorry, that was embarrassing. Anyway, so when they did a culture of this ulcer, they found that it was unfortunately infected with MRSA, and it had gone all the way to the bone. Now, why this is important to go over is to understand how rapid this can happen with a patient. So within 24 hours, I got a call that my father was going to have his leg amputated. So with a diabetic patient, so when we go over ulcers, we have to understand that some of it is because there's a percentage that can have the ulcer develop because of neuropathy, and they can also have the loss of proper vascularization to that area. And in some cases, patients can have both. So if they don't have the sensation we're taught to check the bottom of the foot, teach our patients to look at this. If they don't have the vascularization, the complications are even more severe, because even though they did the antibiotics with my father, to get those antibiotics where they needed to go did not happen because he doesn't have the vascularization to help him in that way. So my father had his lower extremity amputated below the knee, and then 24 hours later developed a wound on the opposite foot. And I was there to witness this. And at 10 a.m., he had a small red lesion. And by 1 p.m., his entire lower extremity to the knee was red. So my point in addressing this is to show you how rapid this can progress and how debilitating this can be for our patients if not detected. So he had to have his second leg amputated 24 hours later. So I want to go over this, some of the research out there, because there's really, really good research, but unfortunately not enough. So if you look at, there's a nice article, and I'm going to post this for all of you so you have this information. But so one of the article was an update on the management of the diabetic foot ulcer, and this was published in 2018. So the mortality rate of just having a single diabetic foot ulcer is 5% in the first year. At 5 years, if a patient's had a diabetic foot ulcer, the mortality rate increases to 42%. To me, that's amazing. It's unacceptable. And so the treatments that we have surgical debridement, there's dressings to promote healing. They educate the patient on keeping their wound moist. We look at the vascular assessment and working on infection and glycemic control. So if you look at the percentage of diabetics who can encounter this, it's 19 to 34% on average. And 5 to 15% of these patients will unfortunately have to have an amputation. Patients who have a diabetic foot ulcer are 2.5 times greater to die, to have a risk of death, compared to diabetics who do not have an ulcer develop. 2.5 times more likely to die. So this is something that is huge that we need to address in the clinic. And so Will Boyd did a wonderful podcast a few weeks ago when he was going over the geriatric adult management of the older adult. And he talked about how, as clinicians, one of the best ways that we can look at our patients is to assess their foot, take their socks off. So to me, if you have a patient who has diabetes in their history, it's unacceptable to not take their shoes off, to not take their socks off, and to not do a strong assessment of their foot, because this is something that we can catch. So the recurrence rate for patients who do have one is 40% in 1 year. And this is interesting too, and sad. Treatment for these diabetic foot ulcers cover 1/3 of the total medical costs of all diabetic management, 1/3. And then what this article talked about, which is sad to me, is that the National Institute of Health granted $7 million for diabetes research in the years of 2002 to 2011. And only 0.17% of those funds were allocated to the research of the diabetic foot ulcer. And if you think that it affects 1/3 of all diabetics and is 1/3 of the cost of diabetic care, to me, 1.17% of the research going towards this is unacceptable and sad. So we needed to know, as clinicians, to know the risk factors. So if a patient is a high risk factor, meaning that they have the neuropathy, meaning that they have vascular issues, those patients need regular assessments. So it talked about empowering your patient, and patients were shown to have a greater likelihood of being empowered if they were taught proper diet and regular exercise. Well, that's where we come in. And talking about how, of course, patient education, avoiding external factors, so shoe wear. And, if a patient tells you that they have there's a little redness on their foot, that's something that's important to address right away. They have to have the proper shoe selection. Something that is important to teach them is not to walk around their house barefoot, that they have to have shoe wear on and the proper shoe wear, and having that multidisciplinary approach. So another article that I found very wonderful was it examined, does physical therapy and rehab improve the outcomes for the diabetic foot ulcer? And this was published in 2015. And again, I'll share this with all of you. So it talked about, unfortunately, there's a 5-year mortality rate post-amputation of 50%. So preventing that amputation, let alone preventing the onset of an ulcer, is huge, because if we can get this under control as clinicians, we can make a huge difference with our patients. So, so this is interesting. So the most frequent cause of a non-traumatic amputation worldwide is the diabetic foot ulcer developing and getting infected. So it's the #1 cause, and it's estimated that every 30 seconds, a foot is lost secondary to diabetic ulceration complications and infection. So how do we manage this? So it's important that we determine the musculoskeletal complications that we can address as clinicians. So we need to look at the structure of the foot. If we see that the foot is getting rigid, or we see that there's some sense of calluses or something that's unusual with range of motion and flexibility, we can change that. We can teach the patient some exercises. We need to do the proper assessment, of course, for sensation. And so to review, we know that the monofilament, if they can't detect 5.07, they lack the protective sensation. It's important that we know that as clinicians and test for that. They share this for free. If you Google it, you can get monofilament sent to you for free. Have them in the clinic and assess it. It takes 2 seconds. One of the exercises that this article mentioned was called the Berger exercise. And this is something I was not familiar with. Now, again, maybe all of you know this, I didn't. So it's an exercise to improve circulation. And what the patient does, you teach them, so they lay with their legs elevated at 45 degrees, and you wait for their skin to become pale. Then you have them sit with their feet dangling on the edge of the chair. And what they do is they do plantar flexion, dorsiflexion, pronation, supination, and they do this exercise for 3 minutes. Then you have them lay supine, and you cover them with a warm blanket. And they've actually did a study in 2016 to assess the real-time dorsal foot peripheral skin circulation following this exercise, and they found it to be effective. Now, again, this was one study, but hey, it seems like a simple exercise unless there's some contraindication for your patient to not do this exercise. But something simple that we can teach our patient to do, and they instructed the patients to perform this exercise 3 times a day. Why not? So to me, I would say that's important. So in review, as therapists, we need to be advocates for our patients. We need to empower them. We need to teach them to not be afraid to assess their feet and to assess it regularly. I know my father had some fear. One of his biggest fears, or 2, were to have dialysis or to have his legs amputated. And the progression of this disease is unfortunate. That's what happens. And it's associated with the longer you have the disease, the higher risk that you're going to have these complications. Catching it early, as with anything that we learn musculoskeletally wise, is paramount. So we can make a difference with our patients. It's unacceptable to have a patient who has diabetes in their history and not check their feet. You have to check their feet. So I hope that I honored my father today and educated all of you on the importance of managing the diabetic foot. So I'll share this research with you, and thank you for listening to me today, and have a wonderful Tuesday. Go out there and make a difference, please. All right, take care, everyone. Thank you for listening and watching. Okay, bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.